Hi, my friends. I think we all know each other from the previous trainings. I hope all you are safe. Uh, Today, we will concentrate to zygomatic area and Malar area. And we know all about the Algeness. It's 100% biodegradable, and we call Algeness as an injectable implant. I will tell you later why we call it injectable implant. And this is 3D reticular structure of the Algeness. You see, this is the reticular structure, and it acts as a structural support, and it has really high G prime, and we will use this high G prime in bone remodeling. You will see later in the presentations. And when we compare with HA, you know it is 100% biodegradable and no residue, and not containing any chemicals, cross-linking agents like BDD, PHD, and no degradation of these cross-linking agents, you know. So no protein, no chemical agents, 100% degradation. And you can see the immediate results because it's hydrocolloid, not hydrophilic. It's no granulomatous activity because no chemical inside, no protein inside, so there is no granuloma with Algeness. And you know we can give excellent shape with this filler, and because of its viscosity, plasticity, and high G prime properties. Yes, when we look to do aging phase, what we see, we lost collagen, we lost elastin, we lost fat, and we lost bone. Especially we lost deep fat pads, not superficial one. And of course, these deformities can be also congenital. And look at bone now. Normally, traditionally solve the problems with soft tissue injections or liftings or surgeries for the facial rejuvenation procedures. And sometimes we forget bone resorptions and bone deficiencies. The correction of the skeletal framework is essential in facial rejuvenation. You see here the old and the young patient CT scan, and you see the bone resorptions, and here in an Asian patient, the resorption in canine fossa. Here also you can see the mid-face skeleton. Here the resorption, the maxilla and the piriform region of the nose. Here the resorptions, the prejaw area in the mandible, and here in this diagram, you can see this area is depository and this area is resorption area of bone. Okay. Here we can see a young patient. It's not by aging, but congenitally, he has negative vector. This line is from corneal line, and you can see the negative vector. In plastic surgery, we do so many implants to correct these kind of deformities. But now we have another choice. You see the implants in the chin, in malar area, in zygoma. This is malar implant. This is submalar implant. This is suborbital and tear-through implant. Too many different kind of implants we have. And you see the volumizing, projection, and we need to have realistic expectation. I put this slide to describe what we have at the end of the injection by means of volume. This is a malar shell implant and medium size. This is A. This is B size, and this is the projection. With medium-sized implant, you see the volume. And even if you want 1 millimeter projection difference, you have to add 1.5 millimeter filler or volume. So for 1 millimeter projection with the same size, you need 1.5 ml or cc volume for this projection. So you have to be realistic in expectation. If you inject 1 ml, you can see you cannot achieve this result. So you may repeat some injections to change the appearance of the face, to replace the bone loss or the soft tissue loss. So you need to be very patient, and you need to inject a few more shrink to achieve this result. So you have to talk with your patient about her or his expectations. These expectations should be realistic. Okay. And now, I told you that the Algeness is really a novel alternative to alloplastic implants. In Algeness, there is no surgery, no downtime, and risks are really low. This is, you know, surgery, and there is risks of anesthesia, bleeding, and sometimes it migrates or dislocates, and it's not easy to correct these implants, but it's easy to touch up in Algeness. And it has very low cost in fillers and 100 biodegradable, and the alloplastic implants, maybe the advantage of them is permanent. But when we compare with HA, you can give really good contouring, shaping, definition, and projection with Algeness, because it's really big G prime and no migration. Okay, let's look to fat and soft tissues. By aging, we lost deep fat pads, not superficial fats. We generally lose deep fats, deep fat pads. You see 1, 2, 3, and 4, these areas. One is lateral SUF, the second is the medial SUF, and this is important. This is the deep medial cheek fat, and this is generally superficial subdermal injection area. This is the buccal fat, this area. But I can say you that we don't lose superficial fats, we lose deep fats. So we have to replace deep fat pads, okay? And you can see here, and how can we understand where is the deep fats and where is the superficial fats? Where is the border? Where is the landmark? And this is the orbicular oculi muscle. Below this muscle, it's deep fats. And above this muscle, these are the superficial fats. So you have to inject the deep fat pad. You have to inject under this muscle. Here you can see the orbicularis muscle, and the lateral, this is the medial band of this orbicularis muscle. And this is a cadaver photo, and this is the injection of filler, and it is in the right plane because it is below the muscle. And this is the right plane to inject your filler. But here you can see some lines: nasojugal groove, mid-cheek furrow, palpebral malar furrows. So what makes these lines? What makes these depressions? Okay, they are ligaments. In here, this is orbitamalar ligament. This is the orbital rim. And this ligament is orbicularis retaining ligament. And below it, there is zygomatico-cutaneous ligament. This is zygomatico-cutaneous ligament. It makes a furrow in nasojugal groove. and this is the orbital rim, and orbicularis retaining ligament is here. And you see here there is orbital fat. By aging, it becomes protruding and sagging here. This is the orbital septum. And when you want to correct the deformity of tear trough or nasojugal groove, you have to inject here. If you inject retroseptally, you make more deformity, you increase the deformity. So please be careful not to inject the retroseptal area. Stay below this septum and here and here, just under the muscle. Here you inject supraperiosteally or SUV, deep fats. In a cadaver photograph, you can see these two ligaments. This is orbicularis retaining ligament in the orbital rim. And here you can see the zygomatico-cutaneous ligament. This ligament creates the nasojugal groove. And so these injections are really important because there is some vessels in this is angular vein. You have to be careful not to injure this angular vein when you inject the deep fat layers here with your cannula. I strongly recommend you to use cannula here. This space is periozygomatic space. When you inject periozygomatic space, please use blunt cannula, 25G or 23G blunt cannula in your injections. Here, this is the arteries of the midface, this is the veins, and this is the lymphatic vessels. You see infraorbital artery, angular artery, and facial artery is the main three artery here, and the same with veins. We have to be careful about these three vascular structure. And you can see these lymphatic vessels. These are lymphatic nodes, and the drainage is in this way, If you do too much filler here, or too much dense filler here, or you can traumatize here, you can see a big swelling in this area. So you have to be careful in this area to prevent from swelling. Okay, for injection, you can do block anesthesia. I never do it, but if you want, you can do block anesthesia with three nerves here: infraorbital nerve, zygomaticofacial nerve, and zygomatotemporal nerve. Normally, this is enough for you. I think the infraorbital nerve. What is the location for infraorbital nerve? This is the mid-pupillar line, and this is the orbital rim, and 7 millimeter or 1 centimeter below this line, there is infraorbital nerve. So you have to inject a little bit medially to this nerve to make a block anesthesia. Okay. What is the cheek axis? This is for ideal female cheek, because the ideal female cheek is ovoid, not circular. So we have to take care about some axis in cheek. And this is one line, and this is another line from oral commissure to lateral canthus and tragus. This area is important. You don't inject below this line. You inject here to give an ideal malar prominence. But this line is also important. The upper border should not extend higher than the limbus of the lower eyelid. Both in male and female, don't go up to this line. Inject here, and this is the ideal malar prominence. Inject only here. This prominence is important in female. For male, it's more medial, not lateral. It's a little bit more medial for male. And here, when we inject, there is a guideline for Hinderers line. These lines are called Hinderers line. It is very useful to separate the bony area and the soft tissue area. Here, the red dots are Zygomatic Malar area, this area. We inject here always supraperiosteally. With Algeness 3.5, the dense concentration, 27 gauge needle or 25G cannula. With 25G cannula, we do linear retrotracing technique. 27G needle, we do some small droplets, small bolus injections on the periosteum. The green one, this is the submalar region. If you need to inject submalar region, you have to stay above this line, okay, just here, but there is no need to go deep to the bone. We just do deep subdermal injection in this line. We generally inject 2.5 deep subdermal with 25G cannula. And here, anteromedial cheek, we can do supraperiosteal injections with small bolus injections on periosteum, or we can do it with cannula. If we use needle, 30G needle is okay. If we use cannula, 25G cannula is ideal for this area. This is prezygomatic space also very deeply. I always add some fillers to paranasal area when I inject to the midface. So this is the paranasal, the apertura piriformis area, and touch the bone. I touch the bone with needle perpendicularly and inject small boluses in this apertura piriform or canine fossa. Okay. There is two injection technique. One is serial puncture deposit injections. With your needle, 27 or 30 gauge needle, you just touch the bone, you do the perpendicular injection, you touch the bone, aspirate, and do small bolus injections. I never do bolus injection in soft tissue, but I can do some small boluses on supraperiosteal plane because it's easy to do massage and disperse it in the supraperiosteal plane, but it is really difficult to disperse this filler in deep subcutaneous tissue, soft tissue. So if you inject boluses, small boluses, just do it on supraperiosteal area, not in the soft tissues. Okay, the other injection technique is linear retrotracing technique. This is with cannula. You can see here, tear trough injection with cannula, prezygomatic space under the orbicularis oculi muscle, you know, with cannula, and palpebral molar groove with cannula. Okay, this is the injection technique, a linear retrotracing technique. The only thing that you have to know, you should be parallel to the skin and slowly withdrawing, not be too quick. Slow injections, small amounts each time, and stop the pressure on the plunger while your needle or cannula is still deep. Because if you go on injection, before removing it, you can see some small lumps in dermis. So you have to stop before removing your cannula or needle. Okay. Before injection, inform patients about the limitations and risks of injection. Okay. What I mean with limitations? This is only one tool. You give volumizing. You are not lifting the skin. You are not hydrating the skin. You are not changing the surface of the skin. So you just volumize. So you have some limitations. You have to warn your patients. And expectations should be realistic. You have to talk about the expectations. 1 ml is 1 ml, not 5 ml like in implants. And avoid body dysmorphic patients. Make a mutual agreed plan before starting treatments, and always take photos. This is very important. And sign patient consent. Before injection, just look for the patient's medical history, including all previous treatments, previous dermal fillers, implants, stress, some cyst, acne cyst, the current medication, any complication, previous complication, allergies, and life factors. Okay. And when we talk about the expectations, this chart is very important in order to me, according to me. This is the degradation time of Algeness product, okay? It degrades linearly, you see? If you inject 1.4, it degrades totally in 15 months. But when it comes to 7 or 8 months, the filler is the half of the initial amount. So you have to explain your patients, if we inject 1 ml, 6 or 7 months later, it will become 0.5 ml. The people think that if you inject 1 ml, 1 year later, it suddenly disappeared. No, it degrades in a linear fashion, in a constantly. So if you want the initial amount, you can add some filler in 7th month, the half of the initial amount, and you can achieve the same result. For example, if you inject 1 ml in right cheek, 1 ml in left cheek, 6 months later, if you inject half each side, you can achieve the same result with the initial amount. Okay, don't treat risky patients. It's infected, vulnerable skin. The risk of, if there is a risk of dental abscess, if they are taking antibiotics, if there is known allergy, the history of several allergy or anaphylaxis. You know all these patients. Don't do injection to these patients, but you can inject patients previously treated with HA, no problem. Just wait 2 weeks and do the Algeness at the same plane, no problem. But this is the very essential. Asepsis is very essential. Clean the injection site with an antibacterial solution. This is very important for us, because if there is any infection or contamination, probably it's due to the injection time, not later. So the asepsis is very important. If it is possible, use sterile gloves and gauzes. Remove all makeups and jewelry before treatment. Okay, you can see an example of injection here. This is young patient, so we don't need to inject too much medially. She wants a little bit lift up the face and a little bit prominent cheek. So we inject only a small part. This is you always try to draw outline of the injection site, and I will do injection with cannula. This is the entrance point. I do just small lidocaine to this area. I introduce my cannula. I pinch the skin and touch the bone. When I touch the bone, you see here, I go deep and touch the bone. When I touch the bone, I go up in the zygomatic arc and touch the bone. And this is 3.5 concentration, aspirate, and linear retrotracing injection here. In a few times, I give the half string, okay? Each time you can give 0.2 ml or maximum 0.3 ml, linear retrotracing way. You see there is not pain. Maybe she can feel some friction, but no pain here. This is 3.5 agarose gel for zygoma. we use the most dense product here in Zygoma, 3.5. Okay, this is lateral SUV, and this is medial SUV. This is one string, 1.5 concentration. I use 1.5 concentration for deep fat compartments here. Why? Because I don't want to have a swelling complication here. So here you can use 2.5 or 1.5 and warn your patients about swelling. Okay, when I push up the skin and go parallel to the bone, I can reach deep fat compartments easily. And never do superficial injection here, never. Always deep injection. If it is possible, supraperiosteal injection. Supraperiosteal injection, always. Okay, when you finish your injection, you can mold this filler, do very gentle massage, not vigorous, and very gentle massage, until you cannot feel the product with your fingers. If you don't feel it, it's finished. Okay, you can see the lifting effect about the filler. We just inject 1.5 string, and this is the result in the right side. Okay, you can see the augmentation in the right side immediately after, and then we will do the other side. Okay, this is another patient. She wants nose job from me, but it didn't work because she was not happy. She want something else, the prominent cheeks. She wanted the prominent cheeks and chin and prominent skeleton, facial skeleton. So this is after 2 sessions. Let's see the video. Okay. We just draw the Hinderers line here, and you see the upper and outer part. There is bone here, zygomatic bone here. We can do linear retrotracing with cannula, or we can do small droplets, small boluses on bone, supraperiosteally. Okay, now you see the difference. We do injections supraperiosteally in this area, and each time I don't do more than 1 string in this part. Never do more than 1 string. So you need time if you want to do the remodelizing the bone and the skeleton of the face. You need time. Don't be hurried. Just do a few filler each side and wait, and 2 months later you can do again. So you need time to change the appearance of the face. Okay, now we start doing that. After 2 sessions, you see here, but we go on. You see the prominence here. You see the prominence of cheek here, and this is after 6 sessions in 2 years with cheeks and chin. Yes, this is before. We remember the before. How was it? And 2 years, we changed the face, totally different shape. Yes, this is another patient, an example here, zygomatic and malar injection, 1.1 ml each side with 3.5, and this is another patient, 1.5 concentration for here and 2.5 concentration for here. And you see, if you inject and correct the negative vector here, it helps the appearance of the tissue fossa. Only tissue treatment is never enough. You have to replace the volume loss in deep layers here. Always inject under the muscle, never inject superficial in this area, always deep. And here another patient, we inject radix, a little bit radix injection, small injection here, 3.5 for prominence, and small injection to chin, a chin injection, nose injection, and small injection with zygoma. Of course, you can do some superficial injections, especially something like this in depressed scars. You have to inject subdermally. We don't inject intradermal algeness, you know, it doesn't migrate, so you have to inject subdermally. But you need to do very, very good massage with your fingers, maybe bimanually. I recommend very good massage, not to have a lump here. In lower face, you know, there is no bone here, so you have to inject deep subdermal over the muscles here with fanning technique with cannula. This is the case. There's the submalar area and the cheek area with cannula. Okay, after injections, the post procedure, no sun exposure, no makeup, don't touch the area the day after, until the day after, and do not smoke. Okay, to avoid and treat the complications. This is an injectable implant, and we cannot compare it with the HA fillers. HA is totally different material. And the protocols and the injection techniques have to be respected in this presentation. The proper injection technique and plane and the correct amount is essential. Okay, let's talk about how we can avoid the complications. Okay, inject subdermal or deep subdermal. We never inject dermal. Aspirate before injection. Slow injection, and don't rush. Take your time. Avoid always large bolus injections, even if you are on the bone surface, on the supraperiosteally. Do not overcorrect, and take your time. Massage when you finish your injection. Do massage until you don't feel the product under your finger. Okay, complications. You know, this table is the complications for all kind of fillers. The early complications and the delayed complications, but we don't see too much complication like other fillers, because there is no protein, there is no bacterial impurities, there is no chemical inside. We don't see granuloma with Algeness. We can only see very, very commonly mid-face swelling. This is very common. And when you look to literature, you can see that 10 to 50% swelling in this area following dermal treatments, even with HA. This is with HA. And here, 25% of patients develop a prolonged malar edema, lasting an average 5.4 months with hyaluronic acid. So this area have a very big tendency for swelling. So what can we do? Okay, sorry. Okay, what can we do? When you do traumatize this area, or when you do large volume of filler, or when you inject too quickly, this is very risky. If you do injection superficial or too deep but too great volume, you can have a lymphatic compression, and again you can see undesirable malar edema. And don't do vigorous massage, gentle massage. Avoid extreme temperatures, hot or cold, avoid them. And if you have any kind of swelling here, the head elevation, manual lymphatic drainage several times a day, and oral steroids are very helpful. If it is an antibody-mediated type 1 hypersensitivity reaction, you can use antihistaminics, also oral steroids. Okay, so let's summarize it. In this area, don't traumatize. In this area, don't do too much injections, don't do superficial injections, and don't use viscose and too dense products, okay? Small amounts and soft products. Okay. If there is infection, okay, contamination through the skin likely occurs during all kind of injections, not only filler injections, all kind of injections you may have infection. And if the situation is not better after 2 days, you can start antibiotics. And if there is abscess, drainage and culture is essential. You know all these treatments. And if you want to disperse the Algeness, you can do it with warm saline injection and massage. You know all of it. And another complication, if you do it superficially, the Algeness, if you inject superficially, or if you do it big bolus, you can see some nodules. If you see the nodules, you have to know that this is temporary. Because the Algeness is 100% biodegradable. If you wait, it will disappear. But if you don't want to wait, you can inject right into the nodule saline solution and hyaluronidase and do massage. But if it is too late, if it is there is some capsula, you can break the capsula with small liposuction cannula mechanically, or you can inject triamcinolone 5-fluorouracil inside the lump and do massage. Okay, but we never see this. If you do proper injection, you can never see these kind of problems. And vascular compromise. We did a study in Izmir University, and we saw that it is really difficult to have a vascular compromise with Algeness. You cannot obstruct the vessels with Algeness. You can only use antithrombotic agents, and that's okay for vascular compromises. We have never seen any vascular problems with this filler. Okay, and finally, if there is any problem, high resolution ultrasound, even if fat injections, even if HA injections, all kind of injections, high resolution ultrasound is very helpful for you to see the location of the lump or the mass, to determine the size, the type of the material, if it is solid or kystic, or if it is a granuloma. And if you are doing treatments, follow-up treatments, it's very helpful. So the one of the first choice to detect what happens there is ultrasound. And you can see Algeness training in our website, www.trainingalgeness.com. You can go there. This is only for doctors and free for you. And you can download Algeness photo application from this website. And you can, please don't hesitate. If there is any problem or any questions in your practice, you can mail to clinicalsupport@algeness.com, or you can contact with me directly. Please don't hesitate. This is my personal mail and this is my WhatsApp number. And thank you for your attention.